It's a great pleasure to be here. So my name is Alex Todhunter-Brown. I am Professor of Evidence Synthesis at Glasgow Caledonian University, and I'm one of the founding members and one of the co-leads alongside Maureen and others of the Cochrane Co-production Methods Group. So it's an absolute pleasure to be here today, and thank you everyone who's joining us. It's great to have this day with the Cochrane Co-production Methods Group, and we're really excited about the next couple of presentation sessions. So these are the aims of our group, and as Maureen has said, the whole goal of this first presentation session is really just to give some examples, some real life examples of how people have been involved in a practical sense within evidence synthesis. I've got the rather dry job of setting the theme first. So my role in this introductory talk is really just to go over some key definitions and terminology, introduce a framework that is used within co-production and evidence synthesis, and then I will be handing over to the following speakers who will be giving the live examples of co-production in evidence synthesis. So starting with terminology and definitions, like many areas of research, it can be quite a confusing field with different terms used at different times. But the term involvement, as in public involvement, with this definition here of research that is done with or by the public rather than to, about, or for them, is now, I think, very well accepted. Perhaps the slightly confusing term is that definition of involvement is also used in some parts of the world with the word engagement. So here in the UK, we tend to use the word involvement with that definition, but in other parts of the world, so example, Maureen in Canada would tend to use the word engagement, but meaning exactly the same thing. So in these presentations, you may hear both terms being used, but we are referring to the same thing. When we talk about co-production, there isn't one single sort of accepted definition of that. The words on the screen at the moment are the words that we use as part of the Cochrane Co-production Methods Group to describe what we mean by co-production. Personally, what I like to say is that co-production is all about working together in a partnership in order to produce evidence synthesis. And I think that's the key takeaway from this, that it is working in a partnership with people. Co-production arguably is a type of involvement. However, I don't think there is any clear distinction between what's co-production and all involvement. There's a very blurry line between the two things. And we almost made a deliberate decision within the Cochrane Co-production Methods Group not to try and delineate between what we mean by involvement and co-production. Co-production is a type of involvement, and the distinction is blurry. And I think we're all happy with that in terms of how we're using those terms. So given that co-production is working in partnership, who are we talking about working in partnership with? Again, a whole lot of different terms have been used, and these are different in different parts of the world and are within different research contexts in terms of who we mean by who we are working with. However, I think the take-home message here is that we're talking about involving people whose primary job is not directly involved in the research. So people who wouldn't traditionally be part of that research team doing the evidence synthesis. However, people is quite a loose term, and I think there has been the recognition that there is a need for a sort of collective term to describe what we mean by all the different people we might involve. A number of different terms have been used around the world at different times, but there has more recently been the term interest holder defined, and that QR code takes you to the paper that justifies and describes and defines the term interest holder. So that's defined as groups or people with legitimate interests in the health issue under consideration. And I think if we look at recent publications coming out, the term interest holder is now being fairly widely used and adopted. So that is a term that I will certainly use within my presentation. There have been attempts to define all the different types of people or groups that may be interest holders to an evidence synthesis. And that second QR code takes you to the Muse project, where these 11 Ps have been described. So different people, so patients, public, providers, who may be interest holders in your evidence synthesis. However, the one that I think is most important on that list is the one at the bottom, which is and any other people relevant to your topic of interest. Because it might be that you're doing an evidence synthesis in which the key interest holders are teachers or lawyers or prisoners. So you need to think practically about who has got that legitimate interest in the evidence synthesis that you're conducting. So just summing that up, when we're talking about who we involve, it's people whose primary job is not directly in research. We're using the collective term interest holders, and that may include a whole range of different types of people. I've got a picture here of somebody wearing many hats, because to me, this is always an important thing to think about when you're thinking about who is involved as an interest holder. Very few people only have one hat. So myself as a researcher, principal investigator, I may be a patient or a caregiver for some reviews, some systematic reviews, and many people will have multiple hats at any one time. And I think that's an important thing to reflect on, the different perspectives that an individual might bring. So it was a whistle-stop tour of some key terminology and definitions. So now moving on to talk about the active framework, which is a very simple and pragmatic framework aimed at how we might go about describing the methods of involving people, interest holders, in evidence synthesis. So the background to the active framework is that I carried out a Cochrane systematic review. It was an update of a Cochrane systematic review in 2014, in which I involved a group of stroke survivors, carers, and physiotherapists. And at the time of doing that in 2014, I couldn't really find any guidance about how, as a researcher, as an author, I should be going about involving people. There's a paper there describing how we did involve people, but really the follow-up from this was conversations with Cochrane, which led to the ACTIVE project, ACTIVE standing for Authors and Consumers Together Impacting on Evidence. And what we did within the ACTIVE project was to carry out a scoping review to identify published evidence syntheses in which interest holders had been involved. And then we pulled out descriptions of what had been done and tried to sort of unpick and make sense of that. The key output of the ACTIVE project was Cochrane's Involving People Learning resource, which is still available on the Cochrane website. But in order to bring together the information from the evidence syntheses that we found describing interest holder involvement, we had to have some sort of framework or structure to think about which components of information were important to bring into the learning resource. So it was that led to the ACTIVE framework. So the ACTIVE framework, very simple, just involves these 5 different domains that we feel are important to describe when you're thinking about methods of involving people within an evidence synthesis. The QR code there takes you to the paper that describes the framework, but I'm just going to talk through each one of these in turn. So who was involved? We've already talked a lot about who was involved earlier in this presentation, but really at the most basic level, I think we're thinking of 2 key categories. Those people with lived experience, patients, carers and their families, and then other interest holders who are quite likely to be people in professional roles, such as health professionals and policy makers. Domain number 2 is about how people were recruited. Where did the people who were involved come from? And when we carried out that scoping review and dug into all the different examples of how people were involved, we found 2 distinctly different ways of recruiting people to be involved. So there was the open approach where people put up posters on the walls of their university, or they did social media postings, and anybody who was interested could come along. So maybe there was an open workshop and anybody could come along. Within that, there were 2 very different models again. So there were examples where the authors might hold one workshop or maybe two workshops, and anybody could come along at any point. So we had different people at the two workshops. So that was what we called flexible, a flexible open approach. And then there were those examples where at that first meeting when people came along, the authors then went, right, this is our group. Those people that came to this first meeting are now our group of interest holders. And then there were the examples where people use this closed approach. And very often this approach was about involving people through invitation. So it might be reaching out through the researcher's own networks to identify a physiotherapist, a psychologist, a stroke survivor who had the relevant interest. In many cases, or maybe not many, but some cases, the researchers went to existing groups. So, for example, in my field, we could go along to a stroke survivor support group and speak to the stroke survivors at that group. And we also found examples where people were using purposive sampling, much the same way as you would do within qualitative research. Moving on to the third domain, what happened? So what actually happens once you formed this group of people? Well, we found that there were two main things that we felt should be described. The first was the approach. And again, we found some distinctly different ways of involving people. So we had some examples where people formed an advisory group. It might have been called a public involvement group, a reference group, and that group had continuous involvement. They were in contact with the research team the whole way along, and maybe had several meetings, and they stayed on the whole journey of the evidence synthesis. But we also found examples where there was one-off, one-time involvement, one workshop, perhaps with a specific aim, for example, to identify and prioritize the outcomes of a systematic review, or a one-off workshop to interpret the evidence and think about the implications of the results. And then we also find many examples where researchers were using a combination of both those things. So they might have an advisory group, but then also be holding some additional one-off meetings or workshops. And then the other important thing was that method of interaction. So were people having face-to-face meetings, online meetings, or in fact having no direct interaction at all? And we did find a number of examples where there was involvement of interest holder, but it was perhaps done through surveys. So people conducting surveys to find out which outcomes mattered most to people affected by the topic of interest, and then maybe prioritizing it. So no direct interaction, but still public involvement. And the fourth domain, when was their involvement? And we've used this circle of the different stages of a systematic review and really encourage people to think about when in the review are you going to involve people. When we looked across the examples that we found within that scoping review, we did find examples of people being involved at all these different stages. The most common, though, was what we called a top and tail approach. So this was where researchers were involving interest holders at the beginnings of planning stages of an evidence synthesis, and then also at the tail. So maybe at that stage of interpreting findings. And then the fifth domain is how much involvement, or rather, how much control did the people involved have over the decision making? And as part of the active framework, we came up with this sort of hierarchy of different ways that interest holders may be involved. Now, arguably, that bottom one in purple, receiving, isn't actually a form of involvement because people are just receiving information, not actively being involved. However, that is there on that list because we did find a number of examples where it was described as involvement, but actually when you dug in and you looked to see what people were doing, they were just receiving information. So moving on then to thinking about actually what's happening now in terms of involving people in evidence synthesis. So as I've said, the active framework came from a 2018 scoping review. However, we have just done a fairly major update of that. So we pulled together all the published evidence syntheses in which interest holder involvement was reported between published evidence syntheses between 2016 and 2024. We found 272 which said they had interest holder involvement, and of those, 51 we judged to have quite a good description. So we dug much more into those 51 in terms of extracting details of what they were doing. So we think about just those 51 papers. The most common who to involve was a combination of patients, carers, and other professional interest holders. So about 60%, 59% involving that combined group. But in fact, a quarter of those examples were only involving patients and carers only, so people with lived experience. In terms of how people were recruited, by far the largest proportion, so 59%, was that closed group, often with authors reaching out through their own personal networks to recruit people in. The reporting of this is still really poor. So in over a third of those examples, actually, there was no reporting at all of how those people were identified. Thinking then about what happened and when it happened, across those 51 examples, 22% of them had that model of having an advisory group or reference group that were involved throughout. But then these percentages show the percentage of those 51 studies where there was involvement at different stages within the evidence synthesis. So some sort of key thoughts from that is that obviously there are examples of involvement at all different stages, but by far the largest percentage is there at number 10, interpret findings. And when we looked across this, we found that 25% of our examples had that top and tail approach. So involving people at both the beginning and the end, but not really actively involving them during the sort of conduct of the review. We found that mostly people were having meetings and group discussions, but not using any sort of formal methods. But we did find some evidence of more formal sort of methodological approaches, like using things like the nominal group technique. So then bringing that together and looking at number 5, the how much involvement or how much control is really poorly reported and really difficult to pull out from the published papers. But we would say that most commonly, the interest holder did have some sort of influence or control, but they were not leading the evidence syntheses. So just bringing that then all to sort of a conclusion and summing it up, we're seeing that co-production is working in partnership with interest holders. There is evidence that at the moment that interest holders can and have been involved at all the different stages of an evidence synthesis, but most commonly this is often the top and tail approach. And those 5 domains of the active framework could support your sort of planning of involvement. I think if I was to reflect or update the active framework that was developed as part of that project with Cochrane, I would sandwich it between 2 more questions. Why work in partnership? I think that's absolutely crucial to ask at the beginning, and that answer to why you're working in partnership should inform a whole lot of decisions in terms of planning involvement or co-production. And then at the end, thinking about how did it go? What was the impact of involving people? What changed in the evidence synthesis as a result of involving people? And then finally, just to say that all the papers that I've mentioned during this presentation are all listed and available on the resource page of the Cochrane Co-production Methods Group website. Thank you very much. I'm going to stop sharing there.
Thank you so much, Alex, for setting the scene. I don't see any questions right now in the chat, but in 1 minute challenge, could you address a really important question that was on the discussion board about whether the active framework can be a limitation? Like, how do you interpret that to actually doing co-production?
So I absolutely agree that the active framework is limited. You know, it was, as I've said in the presentation, it was designed with that goal of describing basic information from published evidence syntheses about interest holders were actually 2/3 of them didn't say anything more than we had an advisory group. So it's limited from that, but I think it's a really important starting block to have some sort of structure of where we start building this from. Of course, we don't just want to know who and that simple thing of were they a patient or were they a professional. There's all sorts of other information that we would like to know about equity characteristics, for example, of the people we involve. But I would argue that given that we had nothing a few years ago and we were starting on a blank page, having these 5 simple domains to start our thoughts and to build from is not limiting. So it's limited starting point, but it's a basic structure to start building from would be my answer to that.
Well, thank you so much, Alex. And now that we've set the scene, we're going to hear three presentations that are, going to show you how it can actually, how it actually looks. So we're going to start with Andrea Tricco. So over to you, Andrea.
I'm really thrilled to be here today with all of you, speaking about a topic that's very close to my heart. So as Alex mentioned, Alex set the stage really nicely for all of us today. So thank you so much for that, Alex. And I'm going to focus predominantly on my experience co-producing with patients and the public. And Maureen asked me to introduce myself. So I am the executive director of the Lee Cushing Knowledge Institute at St. Michael's Hospital, which is part of Unity Health Toronto, where I've been a scientist for the past 15 plus years. I'm also a professor at the University of Toronto, and I'm also co-editor-in-chief of the Journal of Clinical Epidemiology. So just to start with a land acknowledgement for Unity Health Toronto. So where we live, work, and operate is Toronto, which is part of the Dish with One Spoon Covenant Territory, and is the traditional and ancestral lands of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Haudenosaunee, and the Chippewa and Wendat nations. And I would invite everyone to reflect on the relationship with the land that you live on. And here is a resource where you can actually look at the name of the traditional land from which you are joining us, and you can learn more about that. So definitely encourage everyone to reflect on the land that we have the opportunity to work on. So a few disclosures. So I do receive a stipend as co-editor-in-chief of the Journal of Clinical Epidemiology. I hold a Tier 1 Canada Research Chair in Knowledge Synthesis for Knowledge Users. So as Alex said, we all use different terminology. I'm based in Canada, so you'll hear me using terms based from our funding agency, which is the Canadian Institutes of Health Research, or CIHR. I'm also the nominated principal investigator of the CIHR Spore Evidence Alliance. Strategy, which stands for Strategy for Patient-Oriented Research. And so you'll be hearing me speak a little bit about that today. And then also I sit on the editorial board as an unpaid member of other journals in the field. And also to note that I was the chair of the JBI Scoping Review Methodology Group for a few years. So just kind of going forward from what Alex was talking about. So this was a paper that we wrote in 2018, thinking about co-production in knowledge synthesis, and just thinking through about what would be some of the barriers and facilitators. Because I think before we get into this work, it's really important to think of the challenges and opportunities to do this well. So when we looked at the 31 studies that were included in this scoping review, we saw that if the knowledge user had a particular level of expertise, this was seen as being a facilitator in about 17% of the studies. However, we saw in about 11% of the studies that time was actually seen as a barrier. So we do want to make sure that we have adequate time when we're doing this engagement work, and want to be clear that it does take time to do this work properly. Also, we saw in about 8% of the studies that early relationship building was also seen as a facilitator. So I think this is particularly important when you're working with patient and public partners, because you want to make sure you have that trusting relationship before you start your knowledge synthesis or whatever research project that you're going to be focusing on. And based on my experience doing this for 15 plus years, it really is about communication. So we try to provide as many updates as we can when we work with our knowledge users. So providing weekly updates to the entire team, having meetings, regularly, weekly, bi-weekly, monthly, depending on the timelines for your project. But just to mention that communication is so important when you're doing co-production work. This is a paper written by one of my brilliant colleagues and friends, Daniel Pollack. She wrote a really nice paper on engaging with knowledge users. So just building off of what Alex said, when we're doing this work, you want to develop a plan for it. You want to make sure you have appropriate resources. So will you be providing compensation to your patient and public partners who are volunteering their time? So can you provide them with some sort of a stipend or hourly rate? It really depends on your institution. But that's something to think about. Provide capacity building to them so that everyone is on the same page, and in particular actually providing capacity building to researchers, which is part of the reason we're doing this today, so that people know how to do this well. Develop your recruitment strategies, which I think Alex covered really nicely in her talk. Consider what some barriers might be. So for example, if you're engaging patient and public partners, they may have caregiving challenges. So is there a way that you could provide them for compensation for caregiving? Can you provide them with transportation if there are in-person events? Just trying to think through, different barriers so that people can fully engage and participate. You want to create a positive environment so that, they want to come back and they want to continue working with researchers. So that's something important to keep in mind. And show appropriate appreciation. So as I said, are you providing them compensation? Are you providing them authorship? These are things you want to think about before you start the project. Also thinking about report the engagement transparently. So I think Sophie is on the line. So we have the GRIP 2. When we're working with patient and public partners, that's often what we use as our reporting guideline, but there are others to think about as well. And then evaluating your engagement. So using an assessment tool like the peers when you're working with patient and public partners, and evaluating to make sure that everyone felt they had the opportunity to engage and that they were happy with how the project went. So I'm going to give, as Alex said, we had to give some kind of real lived experience. So this is a paper that was published in 2012. We published this paper as part of the CIHR Drug Safety and Effectiveness Network, where we were working with policymakers on different drug safety and effectiveness topics. So here we were looking at cognitive enhancers for patients with mild cognitive impairment. And so this one, I would say we had minimal co-production. We had research and clinicians here, so we did have that content expertise. And then although that we did have some policymaker input into our question development, it wasn't really integrated throughout the whole project. It was more like at the start and at the end. As Alex was mentioning, that is a very common type of engagement when it comes to knowledge synthesis. So that's kind of what we did here. We didn't engage with any patients or public partners, and also no trainees were engaged either. So this, I would say, is minimal co-production. Here's another example where we had intermediate co-production. Again, this was for the Drug Safety and Effectiveness Network, where we're looking at cost effectiveness of seasonal influenza vaccines in older adults. So we had researchers and 2 clinicians. We also had a trainee at this point. We also had policymakers from the Public Health Agency of Canada. They were involved with our conceptualization, with our literature search terms, study eligibility, and data items. However, they did not co-author this final paper, even though they were involved in multiple steps, and we didn't have any patient or public partners engaged. Moving on to the third example, this is where we had extensive co-production, and this would be one of the papers that I'm most proud of the many papers that I've had the opportunity to publish with my team and colleagues internationally, and some of them are on the line here today. So this paper I'm particularly proud of because we were looking at a really important issue, so looking at social isolation in older adults who had experienced the fall. And here we had 4 policymakers from the Public Health Agency of Canada, we had clinicians, and we also had a patient partner, all as co-authors. We had 2 trainees, and everyone was engaged in the project from start to finish. So they helped with conceptualization, our literature search terms, study eligibility criteria, our data items, interpretation of the results, and they revised the draft papers. So this was very extensive co-production. It took us a while to get done because, the range of knowledge users that we had on here, and it led to really interesting discussions on how to frame the evidence and what the results meant in terms of interpretation. And again, something that I'm very proud of in my professional career would be this example. I'm going to move on to talk a little bit about the Sport Evidence Alliance. And so with this initiative, which ran for about 9 years, we're coming to a close and we'll be celebrating our final closure of this initiative in April. So looking forward to seeing many of you at that closure. And so in this initiative, we had patients integrated in all aspects of our initiative. So we had 2 patient-led courses, which I will talk about on the next slide. We had principal investigators, which we call them knowledge users. So they really functioned as principal investigators with lived experience on our grant. We also did 2 patient engagement evaluation papers. We had 98 patient and public partners who submitted projects. I'll talk about this. 23 of these led to fully funded co-led projects. We had patients serving on our committees, and we had co-chairs of committees as well. They acted as peer reviewers for our annual seed grant that went for early career researchers and trainees. They were engaged in multiple projects across the whole spectrum of the initiative. And then we had multiple capacity building events and multiple learners engaged. So do want to give a huge shout out to Maureen Smith, who's just amazing to work with. And so she co-led these 2 courses. We did this in 2021, where we focused mostly on rapid reviews just because of COVID and being bombarded with all the requests. And then we also did it in 2022, and we expanded this out into other types of knowledge synthesis as well. So we had 2 experienced patient partners, so Janet Gunderson and Maureen Smith, who co-led these projects. They co-delivered it. And we had about 50 patient and public partners engaged here. And 90% felt that the course helped them achieve their learning goals and that the learning experience was valuable. So we did publish this paper in the Journal of Clinical Epidemiology. So I'm happy to share that citation if people are interested to learn more. And just to say that we can't do this work without thinking about ethics guidance. This is a document that was put forth by CIHR. So when we're thinking about ethical partnership, we want to have mutual respect for different ways of knowing and interacting, equitable participation and rights, reciprocity and shared commitment, personal integrity. And in this way, when we have respect, concern for welfare and justice, we hope that these research partnerships foster trust. So very important for us. We can't think about even doing this work without coming from an ethical standpoint. And part of it as well, in Canada, we talk a lot about cultural safety and trying to provide cultural safety training. And just want to give a shout out to Dr. Angela Mashford-Pringle, who developed a new respect training. And this was provided for free to everyone that was part of our initiative. And so this was to address systemic anti-Indigenous racism by providing content that embeds power, privilege, and positionality. So here are 3 Ps. Alex was talking about 11 Ps. Well, here are 3 Ps, and thinking about critical self-reflection throughout. So Angela has done a lot of work in this space. And if people are interested, we'd be happy to share that resource. Also want to shout out another framework here for meaningful and inclusive patient engagement. And this is really coming from a trauma-informed lens. So when we're working with patient and public partners, there is evidence saying that there could be harm And so in particular, we could re-traumatize patient and public partners. So we really want to try our best as researchers not to do this. So really coming from a trauma-informed approach, intersectional analysis, and critical reflexive practice. We want this to be meaningful, inclusive, and safe when we're working with patients and the public. So this is another resource that I would suggest if people are thinking of going into this work, that they would definitely take a look at this and try to incorporate it in some way into your co-production research. So one thing with the Spore Evidence Alliance that was quite unique is that we provided funding for these patient-driven research projects. So how it worked is that patients and the public submitted topics, and then we did a modified James Lind Alliance approach to prioritize these topics. So we had more than 100 topics that came in, and we prioritized 23 of these. And so the patient or public partner who submitted the topic co-led the research. So these were all knowledge synthesis projects, and the patient and public partner actually had a preference over which research team that they wanted to work with. So more information is available on our website, but we have the 23 patient-driven knowledge synthesis projects listed there. And just to read out a few quotes that we received from people that were engaged in these projects: patient partners add heart and soul to the project. It challenges the research codebook and encourages collaborative learning. It personalizes and humanizes the research process. So as part of this initiative, we also established these 5 communities of practice, and this was to support patient-driven research teams when we had co-leadership. So for every one of the 23 projects, we had a research lead and we had a patient partner or public partner co-lead that. And so the objectives of these communities of practice were knowledge sharing, networking and collaboration, capacity and skills development, as well as advocacy. So we are in the process of writing up this paper, and we have quite a few lessons learned. If you're interested to learn more, it is on the Spore Evidence Alliance website. And just to note that even when the initiative comes to an end, that we will be still making these resources available on our website, along with all the publications. I'm just going to spend 1 or 2 minutes talking about equity and want to give a shout out to Omar and Vivian Welch and others who have been working on this for many years. So again, I don't think we can talk about patient engagement without talking about ethics, as I said, as well as equity. So this was a very practical guidance that we wrote, where you can actually think about equity in all stages of your evidence synthesis or knowledge synthesis process, as well as guideline process. And just to give you a quick snapshot of this, so when you're doing your protocol, you want to make sure that your team is representative of the topic, so including patient and public partners with lived experience as an example. Completing a self-reflective exercise. We have a nice example on the Spore Evidence Alliance to think about power and privilege in your own life and thinking about who may have a voice on the team and who may not have a voice, and encouraging that everyone is there to voice their opinions in a safe way. Other examples would be using equity-specific filters and databases when you're doing your literature search. Perhaps when you're screening, your eligibility criteria may focus on specific equity dimensions. You may want to use the Progress Plus or other frameworks when you're abstracting variables. So now we do this on all of our knowledge synthesis projects as an example, and also thinking about considering intersectionality. You may want to think about if those studies were powered correctly for equity, if they did any subgroup analysis as an example, and then report using the PRISM Equity extension or the SAGER guidelines as examples. So this is just a quick snapshot of how to incorporate equity when you're doing your knowledge synthesis. And that's all from me today. I love hearing from you, so please feel free to send me a note if you have additional questions. I don't know, Maureen, if we have time for 1 or 2 questions, but again, if we don't, please feel free to reach out to me anytime. And that's it.
Thanks,
Thank you.
Andrea. We do have time for 1 question. So does anyone have a burning question? Either put it in the chat or mute. Okay. I don't see, I'm just checking. I don't see anything in the chat. So I will use my chair's prerogative and take one from the discussion board. And just, I know this is a big reflection time for you, Andrea, because you are wrapping up an incredible project. But can you just in a minute tell us what's your no, I mean what's your biggest what's your really thought on how we're really developing the future evidence base for this co-production that you've been working so hard on? Like, where are the gaps in the evidence base?
Yeah, thank you so much. I mean, I think it's amazing that Cochrane has the co-production group now, and I think we're trying to fill some of those gaps, which I think is really exciting. And for me, I think it really is about the next generation. So seeing, I think I see Ellie Quinn here on the line with her People's Review. So shout out to Ellie and others here that are really, pushing this field forward. I think it really is in their hands now. And as our more senior scientists and senior researchers, I think we have to do whatever we can to support the next generation of scientists. And of course, Catherine Stratton, my PhD student, who's just completely brilliant and has been doing so much in this space. And so I feel the future is very hopeful because we have these brilliant early career researchers and trainees that are really going to carry the torch forward. And I feel it's my job, as a more senior scientist, to really support them and provide them with the tools and the networks. And I know, Maureen, you've done so much for Catherine, so huge shout out to you and a huge kudos to you for all that you've done for the early career researchers working in this space.
Thank you, Andrea. Yes, champions. We need champions from every interest holder group, actually, to get the job done. All right. Thank you so much. And lots of food for thought and lots to think about, all the different considerations that you raised. So Lyndsay Alexander is our next presenter. Unfortunately, she's been taken away for a family emergency, but she's provided us with her recording of her session.
Hello, my name's Lyndsay Alexander, and I'm an associate professor in the School of Health at Robert Gordon University in Aberdeen. Today, I'm presenting on a review and piece of work that we've done as a team working in tendinopathy, just to share an example of how we've applied the active framework in trying to co-produce evidence synthesis. As part of my declarations, it's just to say that I am a board member for the Cochrane Co-production Methods Group. I'm also the co-director of the JBI Scottish Centre for Evidence-Based Practice, and I am a musculoskeletal physiotherapist as well. So while I clinically am interested in people who live with musculoskeletal conditions and the best evidence to manage them and support them to live well, I'm also a methodologist and interested in how we can conduct systematic reviews better and ensure that we have meaningful results that we can use in practice. For today's presentation, I'm referring to a project that we conducted a few years ago, and it was funded by the National Institute for Health and Care's research. So following on from Alex's presentation on the active framework and the 5 components to consider, the project I'm using as an example today to talk through is an NIHR funded project, and the project began in 2020 and we published the findings in 2023. The focus of our review was the use of exercise therapy for tendinopathy, and we did a series of evidence syntheses in this work. It wasn't just one systematic review, and If you're interested in the actual project report, the DOI is on the screen. So to give an overview, tendinopathy is a musculoskeletal condition that's quite common. It's where the muscles attach to the bone. It's a sinuous tissue that attaches muscle to bone, and it can become inflamed through different reasons. But the primary management of tendinopathy is exercise and often physiotherapy to help support that, to get it to calm down and improve, or sometimes more chronically to manage that alongside perhaps surgery or other things like injection therapy. Now, the question that the NIHR asked to be addressed was about exercise therapy for tendinopathy, and it was quite open. So we proposed to do a series of evidence syntheses to really identify what the landscape looked like. So what exercise interventions and outcomes had been reported for tendon problems, what interventions or exercise interventions were effective, and what exercise interventions are feasible to deliver and acceptable for people to do. As you can see on this slide here, we had 3 work packages to deliver this. So we started with a large scoping review, and that really we ended up with, I think, just over about 555 included studies in the scoping review. And from the scoping review, it helped us inform what subsequent evidence syntheses that we could go in and do. We did plan to do a series of effectiveness reviews. So I think we'd maybe about 6 in total around those. And we also did a mixed methods, convergent, segregated review, looking at feasibility and acceptability of exercise as an intervention from both patient and provider perspectives. So if we think through the active framework, rather than just go into the project itself, it's the people that we involved in this project. There was a range. So primarily we involved people with lived experience of tendinopathy. So that's just people, the general public who had tendon issues that had required treatment, and also the public that identified as performance athletes, because one of the issues for a tendon or a risk factor is overloading or overuse. And sometimes for performance athletes, they can overtrain and cause an issue with their tendons. So we also included these individuals, but at the same time, we were, very open, and we would have members of the general public who were recreational athletes or physically active in other ways, but did not class themselves as performance athletes. We also included health professionals to involve in the project. So physiotherapists, both working in the National Health Service and also in private physiotherapy settings, private practice, or performance sports settings. We included podiatrists, general practitioners, and sports medicine doctors. And we also included strength and conditioning professionals, as they can commonly work in this area to help manage the condition for people. We recruited people through both open and closed routes. The open recruitment was predominantly via social media. So we, at the time, it was Twitter, which is now X, and Facebook groups. And this was through accounts that the project team had, personal accounts, project accounts, but also we used the Council for Allied Health Professions Research Twitter accounts, so CAPR, and institutional accounts. And we also relied on snowball recruitment through people sharing the open invite. Our closed recruitment involved invitations to existing volunteer patient groups that the team had access to, as well as a focus on recruiting health professionals from one NHS board in Scotland at the time. We didn't employ a specific purposive sampling strategy for our recruitment, and initially the recruitment was more targeted purely due to the fact that the project launched at the start of March 2020. I think we had 2 weeks before the UK COVID-19 lockdown restrictions hit. So I would say that the global pandemic did cause a smaller uptake of individuals initially. However, as we went through the project and with the easing of COVID-19 and just people, for a long time, people had a different focus on their lives and, their lives were upended with having to juggle things. We were able to, widen out recruitment and we were able to involve NHS staff more widely and other health professionals in other areas. So principally, we recruited across London for that. We had a predominantly combined approach to involvement through the project for interest holders. We used a partnership approach for those involved as members of the project in terms of the project management group and steering committee, with regular contributions from interest holders at the meetings, acting in an oversight or management role. We also had some interest holders working across a task, which could involve a series of meetings or emails, which were related to specific steps in the review. And one example was in the development of the search strategy for the scoping review. But these approaches could also be combined where some individuals held a continuous partnership role as a member of the project management group, but also contributed to specific steps in the reviews. The project also used a direct method of involvement via email, Teams online meetings, online and face-to-face workshops. However, we also used an online survey to engage with a wide audience via professional networks to get views of non-UK based clinicians and researchers on the initial scope and review findings, which were we wanted to really cast that net more widely out with UK to specific individuals to help us inform the subsequent reviews that we went on to do. In terms of involvement, you can see here that for each step of the different evidence synthesis conducted, we involved interest holders from the start and throughout the work. While the initial project question was posed by the NIHR, our funding application was based on some patient and public involvement work with people with lived experience of tendinopathy and clinicians treating the condition to help us shape the subsequent questions and to plan our approach for each question. In terms of developing the search strategies, this was an iterative process with everyone involved. There were around 10 iterations, I think, to explore clinical and lay terms in detail and then to trial them with pilot searches before the final searches were conducted for the scoping review. So this was quite an involved period of time at the start, involved a lot of emails back and forth and Teams messages and meetings to really get to that point that everyone was happy with the terms from both a lay term perspective and a clinical perspective. Across each step, interest holders could decide on what and how much they participated in, although the two areas that probably had greatest involvement were the search strategy development for the scoping review and the interpretation of findings for each review. The extent to which our interest holders were involved in the project varied across individuals, and you can see from the table that their degree of control in the reviews ranged from controlling, where they were working in partnership with the team and collaborating in decision making across authorship of the review and final report, and partnership working for oversights, defining the inclusion-exclusion criteria for the reviews and search terms, but also, working around writing plain language and lay summaries and development of recommendations. They also worked at influencing, where our collaborators were commenting, advising, and helping to reach consensus, but at this level had less control over aspects of the review process. And then finally, they also worked at a contributing level, where it was more about providing views and opinions on steps within the review processes. We didn't have any interest holders that were leading with specific responsibilities for carrying out and conducting the reviews, but they did co-author the final reports in manuscripts, but because they didn't lead on it, we allocated them more at a controlling level rather than a leading level of involvement for this. So overall, mapping the project to the active framework across the 5 components, we had a range of people classed as interest holders involved in the reviews. We mixed up our recruitment to try and engage and involve a range of people across different backgrounds from both public perspectives and professional. We focused on online approaches to get things done, which aligned at the time with the COVID-19 restrictions. And we also had a range of levels of involvement from controlling to contributing. We learned a lot about co-producing evidence synthesis from this work, and because the subsequent evidence syntheses that came from the initial scoping review. And it's really helped us to understand working with people together, and helped us to build on our processes for co-production in evidence syntheses. And I hope that gives you an overview of whistlewind tour of the work we've done in this area. Thank you for listening.
Okay, so huge thanks to Lyndsay, and I know she would love to be here to answer any questions. We'll leave it until the end. If there are specific questions for Lyndsay, we can always send them to her or answer them on the discussion board, because I know she was really looking forward to interacting with everyone here. And without further ado, we will go to our final presentation of our set of 4 from Kate Boddy, who will talk to us about the work she's doing. So over to you, Kate.
So I'm Kate Boddy, Research Fellow at the University of Exeter in the southwest of the UK. I'm a member of the Cochrane Methods Co-production Board, Operational Lead for Patient and Public Involvement at NIHR, and the PPI Lead for the NIHR Exeter Evidence Synthesis Group, also known as ISCA Evidence. So my work sits right at the intersection of evidence synthesis and co-production. Alex started this session by talking about terminology, and I just want to make a note of that in my talk too. You'll hear me use the term patient and public involvement and engagement, sometimes shortened to PPIE or PPI. That's simply the language commonly used in the organisations I work with. When I use those terms, I'm talking about the same broader principles of partnership and shared decision-making that sit within co-production. So even if the terminology shifts slightly, we're still in the same universe. Today, I'm going to share 2 completed examples of evidence synthesis co-production. And I'm going to use the active framework to walk us through both examples, asking who was involved, how were they involved, and when did that involvement shape the research? First, I'll talk about an earlier project, a systematic review of quantitative and qualitative evidence on parent-to-parent support for parents of babies in neonatal care. Then I'll move to a project we completed just this month, an evidence and gap map on the epidemiology, causes, treatments, and lived experiences of paediatric acute onset neuropsychiatric syndrome, more easily known as PANDAS. Before I begin though, a brief trigger warning. Both examples involve co-production with parents of children experiencing significant health challenges. I won't be going into much detail around symptoms and things, but these topics themselves can be emotive and you may be affected by them. So please feel free to mute my talk, pause or step away at any point and take care of yourself. So the first question in the active framework is, who was involved? And because of my role as PPIE lead, I'm going to be talking about public and patients rather than health professionals who were also involved, but that's not my focus today. In this example, our key interest holders were parents whose babies had spent time in neonatal intensive care and who had experienced parent-to-parent support, sometimes called peer support. Peer support is practical advice, emotional support, and simply being listened to by someone who had been through something similar. This was the community we wanted to partner with, but this was in 2018. At the time, the prevailing assumption was, oh, it's very hard to involve parents of young children in research. They're too busy. They won't come to the university. Community-based involvement in evidence synthesis just wasn't commonplace. So we had to shift our thinking from how do we get parents to come to research to how do we take research to parents? At the time, outside of work, I was often sitting on the floor of community centres with my toddler, chatting with other parents. And I remember thinking, this is where the meetings should happen. It feels obvious now, but at the time, suggesting meetings outside the university with babies present felt slightly subversive. But that's what we did. So how were people recruited? This project was developed pre-funding with SNUG, a local charity founded by parents for parents, offering advocacy and wraparound support to families impacted by neonatal stays. Leanna, the founder of SNUG, herself a parent with experience of neonatal care, was a co-investigator on the project. She was instrumental in building trust and connecting us to families. We were very clear from the outset. Babies were welcome. Meetings would be held in a familiar community venue, and we met at a soft play centre, which had a regular monthly session for neonatal families. We used flyers, social media, and word of mouth to form a parent advisory group. So there's nothing particularly innovative in that recruitment, but the key was that it was advertising safe, familiar, and parent-centred involvement. Involvement happened in multiple ways, so parents could engage in a way that suited them. Leanna, as the parent co-investigator, attended project meetings. She also met one-to-one with team members and acted as a bridge between researchers and the wider parent group. As I said, we built a parent advisory group, including both parents who had received support and parents who had provided it. And we created a Facebook group for those who preferred a more flexible drop-in model and didn't want to attend in person. Parents could comment on documents, respond to specific questions, and share reflections in their own time online. As PPIE lead, my role was to maximise co-production's influence, attending research meetings, facilitating parent sessions, managing the Facebook group, and ensuring travel expenses and payment were processed smoothly. We did offer childcare costs, though interestingly, no one used it. Parents preferred to attend with their babies, and that decision told us something important about what inclusive involvement looks like. So when was their involvement? Coming back to the review cycle that we saw earlier, you can see here the yellow stars represent Leanna, who was involved throughout, and the blue stars represent the advisory group and the stages at which we held the group meetings. If we look across the review cycle, involvement wasn't tokenistic or late stage, it shaped the work throughout. Parents influenced the inclusion criteria, outcome selection, helped create a plain language protocol version. They added search terms to the strategy, I think 6 in total, and provided questions for fact-finding calls. They aided interpretation of interim findings and suggested wording used to describe themes. And they also helped us emphasize in the final publication. They also helped us what to emphasize in the final publication. And Leanna was a co-author on the paper. The group helped shape the communication plan, leading to an infographic of the review findings. So this wasn't co-production just at the end, it was embedded throughout. Initially, we had been warned to expect high dropout rates. In fact, all 7 parents who attended the first meeting were still there 12 months later at the end. When we asked for anonymous feedback, parents described the experience as empowering, affirming, and interesting. So what helped them stay for the whole length of the project? Well, they told us that it was because babies were welcomed in the room, it was a familiar venue, and a parent-friendly meeting time, and travel expenses and payments were made. But most of all, it was a desire to help others. One parent said they stayed involved because they wanted peer support to be available for everyone. That sense of shared purpose mattered deeply. Now I'll move to our second example, co-production of an evidence and gap map on PANS-PANDAS. PANS-PANDAS, as I said before, is pediatric acute onset neuropsychiatric syndrome, sometimes associated with streptococcal infection, and it involves the sudden onset of severe physical and psychiatric symptoms in children, often around the age of 7. Symptoms can fluctuate dramatically and persist for years, and the impact on young people and their families is profound. So again, using the active framework, we ask who was involved. In this case, it was parents of children affected by PANS-PANDAS. So some similar challenges to example 1, parents caring for unwell children who often have very limited time and resources. But here we also wanted to work directly with children and young people who have PANS-PANDAS, and this required additional safeguarding, relationship building, and flexibility. Because of the sensitivity of this topic, all the images shown in this example are from stock image archives. So how were people recruited? We worked closely with UK charity PANS-PANDAS. They shared our flyer and hosted information on the website. We also created a plain language explanation of public involvement because many families weren't familiar with the concept. The charity has a youth board and a youth worker, Clarice, this is her actual photo, who acted as an intermediary. For safeguarding, we did not have direct access to young people's contact details. Clarice facilitated communication and parental consent was obtained for those under 16. So what happened? Well, we held 4 online meetings with 10 parents with diverse experiences of caring for children with PANS-PANDAS. Outside the group, some parents preferred to share certain reflections by email, particularly around sensitive symptoms. We held 2 online meetings with young people. The youngest attendee was 8 and the oldest was 22, and Clarice co-facilitated. There was also a closed social media group managed by Clarice, allowing young people to contribute flexibly or privately. All those involved were paid in line with NIHR guidance. And importantly, we used a trauma-informed approach. As Andrea mentioned earlier in her talk, this is about prioritizing emotional safety and trust, working carefully to avoid re-traumatization. So, when was their involvement? I've used the same review cycle as example 1, but this is an evidence gap map, so it doesn't fit exactly. That's why I've blanked out 8 and 9. I'll talk about the meetings with parents first. The blue stars represent stages of the process that parents influenced over the 4 meetings. The first parent meeting was simply a listening exercise for us to learn about the experiences, and it was emotionally powerful. It deepened our understanding of the complexity of these conditions in ways no published study could. We then asked parents what the map should include and what they would want to find out. This added 4 extra research topics such as access to services and 6 additional map filters such as health equity. Parents reviewed the draft protocol, adding symptoms such as fatigue and impulsiveness. The fourth meeting helped us interpret the gaps in evidence and improve the usability and navigation of the map. The green stars represent the meetings with young people. The first meeting was attended by 4 young people. As I said, the youngest was 8 and the oldest was 22. It focused on their individual experiences and priorities. They spoke about the severity of their symptoms, the impact on their everyday lives, and what this meant for their childhoods. They talked about loneliness, and they described the challenges they'd faced in trying to access healthcare. It was a powerful session, and it grounded the map in real lives, not just text and papers. The second meeting, attended by 5 young people who were aged 16 to 22, shifted focus to the mapped evidence itself. Together, we explored how well the map reflected their experiences and where they felt important gaps remained. We also gathered feedback on usability. They asked for softer colours, and they wanted clearer guidance on how to use and search the map. So we moved the instructions to appear right at the beginning, one of the first sections readers see. These are small design changes, but they were meaningful. The evidence map was published this month. The report includes 2 forwards written by parents. One wrote, "Clearly identifying gaps is one of the most powerful ways to guide better quality research and ultimately strengthen support for children and families." Another reflected on the vulnerability families face when searching for answers late at night and the importance of having reliable research in one place. This partnership won't end with publication. We're continuing to work together on public-facing materials and on 2 new reviews, one on treatment effectiveness and a qualitative review of lived experiences. Beyond research outputs, this co-production partnership deeply motivated the team. We felt such a strong responsibility, not abstract but personal, to get this research right. So, in conclusion, in these 2 examples, co-production wasn't an add-on. It reshaped where we met, how we communicated, what questions we asked, what we included, and how we shared findings. Across both projects, co-production made the research more accurate, more relevant, and more accountable. And perhaps most importantly, it reminded us who research is ultimately for. Thank you.
Thank you so much, Kate. Wow, 4 excellent presentations with so much food for thought. I am looking over at the chat. Please don't hesitate to ask a question for any of our presenters. I'm going to let you gather your thoughts and wait a few seconds before I say that there are no questions in the chat right now. I do have to say the presentations were so clear and so compelling that, there's not a lot of clarification to do, but please, if you have a question for any of them, put it in the chat or ask us to unmute you and we will let you ask it. Looking around, I'll be quiet. Okay, couple more seconds. All right, I will ask one and maybe that will trigger. Oh, did one just come in? Becky. There you go. Thank you, Becky. So Becky says these questions are for all the presenters, so anyone can chime in. Could you please describe the main benefits of using co-production in an evidence synthesis? How will you describe the why? Is there evidence that demonstrates that an evidence synthesis that uses co-production is more rigorous or the results are more likely to be used by health professionals? Very long question. I hope you're all looking in the chat. I'm going to keep reading it. Would you say that co-production is most useful for systematic reviews of interventions versus systematic reviews of exposures, for example? And finally, would you say because the time it takes to properly conduct an evidence synthesis of co-production, are these type of reviews most likely to be conducted in an academic setting? Whoa, okay. That's a really good question. Thank you, Becky. And I'm looking to see who's going to take the first crack at it. Just looking. And it looks like it's Alex. So over
I
to
could
you, Alex.
I could come in with the why, as I know in my presentation, I sort of finished by saying that I would want to add the why as a sort of sandwiching the active framework and the why question, really informing lots of decisions about what you do in terms of co-production. So I think what I meant with that was, rather than thinking in the abstract way of I have to have co-production, I have to involve people, that you actually really think about what involving people can change within the review and why you're involving them. So, for example, do you know what the outcome measures are? You know, has there been a core outcome measure set, developed with involvement of patients and the public? Or in fact, do you want to involve patients and the public to try and help you select what the primary outcomes and the secondary outcomes should be for your review? Or your why could be about actually you're not quite sure how you define the intervention and what the sort of the inclusion criteria for your review should be. So, for example, in my own field of rehabilitation, there might be questions about what is rehabilitation? Is acupuncture part of rehabilitation? And where you sort of define the interventions that you're going to include into the review, that would be an important why in some of my work. So I like to think about thinking about how the interest holders can change and impact. Where can you hand over a decision to an interest holder, whether that's influencing a decision or actually controlling the decision? And think about that first, because I think that then informs that plan. You know, so you would, if your question's about defining the intervention, you're going to want to have workshops or meetings or activities early on in the process to get your protocol right. Whereas actually, if your why is much more about how best do I disseminate this and get the findings to the people to whom it's going to matter most to, then your workshops and activities will be towards the end of the process. So I'll stop there, but that's some of my thoughts around the why. I'll let the others come in.
Yeah, thanks, Alex. Yeah, it's a there's a couple questions in there. So Kate or Andrea, would you like to chime in on one of the other parts of the question?
Do you want to go, Kate, next, or?
Yeah, I don't mind, but I'm still kind of reading all the questions. Is there one that stuck out to you, Andrea?
Yeah, I mean, I think in terms of the why, so why would we do co-production? So just building off what Alex was saying, that when we're working with policymakers, as an example, so it's to help them make a decision. So they would come to us and say they have this decision to make, and instead of them searching Google, we're going to do a knowledge synthesis, systematic review, or scoping review, or whatever type of method. And I don't think that co-production is most useful for one type of method versus another. It just really is, you know, we choose the method based on what the question is. So what kind of a question do they have that they're coming to us, and what kind of a knowledge synthesis would be most helpful for them. So we try to find out when that policy making window is. So that's why sometimes we'll use a rapid review example. For example, like during COVID, we were doing them within 5 days. And so depending on when they need to make that decision, can we provide them with timely evidence so that they are able to use something other than just expert opinion, or just doing a search in Google or asking ChatGPT, so that they can actually do an evidence-informed decision. And there have been empirical studies looking at this that shows that it actually has reduced costs by using evidence and using evidence-based care. And when it comes to specifically thinking about patient engagement and engaging with communities and the public, there have been some interesting results showing that it actually led to improved health outcomes in some cases. It hasn't been as empirically studied as it could be, But there have been some, James Thomas and others, and Omira Eves did some really nice work, actually, a big meta-analysis looking at this, where they saw increased self-efficacy and increased health outcomes. So definitely takes time. There was also a recent review that I saw recently, actually, that looked at the benefits and the harms. So that's one thing, is that people haven't really done a good job of quantifying the harms. And there are some potential harms, such as some of the things I was talking about, like re-traumatization and, making people even less trusting of the health system. So as researchers, we have to be very careful about that. That's why I was talking a lot about coming from a trauma-informed approach and having cultural safety training and making sure that, we're creating a positive environment so that we're not causing more harm. I think that's really, really important to talk about that. So I think that would be my take on it. I don't know, Kate, if you wanted to add anything.
Yeah, for sure. So, particularly picking up on, I think, Nicole's question, which, yeah, really speaks to what you were saying, Andrea, about the benefits, not just for the researchers, not just for the research itself, but also for the people involved. And Nicole's talking about those as non-researchers. That's really, really key. Andrea's talk picked up on that word, reciprocal. So I think that's a starting point for me as well, is that it has to be both ways. So we don't want to be in a position where we're just taking experiences from people and using those and leaving them, as they were, or worse off, as Andrea's talking about with the re-traumatization. So I think with the examples I shared, the Neonatal Babies Project, we worked really hard to be reciprocal there. Just not enough time to go into all these things in the presentations, but we spent a long time talking to Leanna before we even went out and met parents, asking what would be, what would be appropriate, what would be wanted, in terms of that two-way relationship, where it wasn't us just taking things. And payments go a long way to help with that. So acknowledging people's time, making sure there was lots of teas and coffees and cakes. They sound really simple things, and I don't want to sound patronizing either when I say those things, but it's just about creating that space of respect and that you're valuing people's contribution. We also asked towards the end if there was anything that we could do or that they wanted from us, to kind of acknowledge their contributions to the project. And they wanted to go out for a meal, which was really difficult for them at the time with the tiny babies and the real challenging things they're experiencing. So we arranged that. And we also, you saw the infographic. We took some like little samples from that and framed them and gave them to the people taking part. There's probably lots of other things that I've forgotten about. And just one more point on that in terms of the Pandas project. So in terms of benefits that people get when they partner on research, sometimes the sort of things that you wouldn't necessarily think of. And a lot of the parents in our online meetings were connecting outside of the meeting. So they were hearing each other sharing experiences. And then they said, oh, could we share email addresses? Because it feels like you really have something that I could like learn from you, or, you've been through something similar. So people can, experience that community that they may not be having on their own.
Thank you, Kate. Wow, the questions are pouring in, which is music to my ears. I'm going to go really quickly for a quick answer at 1017 from Mazen Mohammed, which is an interesting question. What if the researcher is a clinician as well? Is that considered PPI? Or if the researcher has lived experience of the condition as well? And somebody want to jump in quickly and tackle that one? That would be great. Alex, thank
I'll
you.
jump in. That speaks to my wearing multiple hats, and I think this is very, very common that people will have multiple hats at any one time. My personal view is but we need to be transparent about the hats that we're wearing at different times and what our role is within different projects. But I certainly don't think it should be a reason to exclude you. You know, if you're a researcher with lived experience, then I think the argument would be that you would bring a lot of benefit to the project, but you probably want to be transparent about the roles, that the who is involved, you know, and what the backgrounds of the different people in the team. So that's the researchers in the team as well as the public contributors.